I'm Nathalie van Havre. I'm the head of education at the European Hematology Association.
Yeah, my name is Hartmut Döhner. I'm a professor of medicine and hematologist-oncologist located at Ulm University Hospital in Germany.
And we're here to discuss precision medicine and AML. Hartmut, I have a few questions for you. Can you describe what precision hematology is, specifically in relation to AML?
Yeah, I think precision hematology or precision oncology has become a very exciting field in the last years, and it describes a stepwise transition from the application of general treatment modalities, intensive chemotherapy, stepwise towards treatment modalities that are adapted to the specific characteristics of the leukemic cells. This may be specific mutations. This may be targeting specific antigens. So there are different ways of applying precision medicine today.
Okay. In fact, can you give us some examples of clinical developments of targeted treatment in AML patients? I know there are a number of molecules that have been studied and are being studied. Which ones do you think are the most promising?
Yeah, I mean, we have witnessed an exciting development in the last 5 years after more than 3 decades of no new drug approval in AML. So basically, 9 new drugs have been approved by FDA since 2017, and I think the precision medicine in AML is probably best illustrated by the successful clinical development of the so-called FLT3 inhibitors, the IDH1 and IDH2 inhibitors, and the BCL2 inhibitor venetoclax. So these are probably the most promising precision medicines that have been developed and which are now approved for treatment of AML.
Mm-hmm. And speaking of these agents, what kind of clinical results can you expect by using these agents, and how can they be improved by combination treatment?
Yeah, I think that's an important aspect. So the experience we have made is, these agents were mostly first evaluated in relapsed refractory AML as single agent treatments, and when you use these novel agents as single agents, they are usually not very effective. So I think it's important to combine these novel agents with the treatment modalities we know, such as intensive chemotherapy in younger patients, or to combine these agents with the so-called hypermethylating agents such as azacitidine or decitabine in older patients. And I think we have learned from these clinical studies that we have to combine these novel agents with standard of care to really exploit the efficacy of these new agents.
Okay. I have a specific question about agents that target epigenetic processes. We're talking about precision hematology, but from what I understand from the paper and other papers I've read, is that we don't fully understand how these agents work. Does that make sense with the concept of precision hematology?
Yeah, that's a good question. I mean, as you say, we still don't know exactly the precise mechanisms of actions of the hypermethylating agents. Azacitidine has been successfully developed, decitabine, and there are now second generation HMAs like decitabine that unfortunately failed in the pivotal study, but there's another development, the oral formulations of the HMAs. This is CC486 that has been successfully developed in the setting of maintenance therapy, and another, the oral formulation of decitabine, the Astex 727 compound. And as you say, I mean, it's in the strict definition, it may not be precision medicine because we don't know the exact mechanisms of action, and it addresses general mechanisms of epigenetic deregulation without necessarily, being based on specific mutations. But it has been shown to be highly effective, especially in the treatment of older patients, and it's now our standard of care, the backbone of all new treatments that we have in older patients.
What proportion of patients would you say are actually treated with targeted agents? Are we talking about a very small number of patients, or is it a reasonable number? How common is it?
Oh, it's an increasing number. I think it has become a very reasonable number, especially, of course, in older patients. I mean, the new standard of care since now 2 years for the treatment of more unfit older patients is the combination of an HMA plus the BCL2 venetoclax. And venetoclax, I mean, we discussed it, is one of the successful developments of precision medicine. So that is the new standard of care in older patients. And AML, we need to recall every time it's a disease of older patients with a median age nowadays of about 70 at time of diagnosis. So a large proportion of patients is being treated with this combination. With regard to younger patients, we still have only one approved precision medicine treatment. That is the combination of intensive chemotherapy with the FLT3 inhibitor midostaurin. But FLT3 mutations are very common in younger patients, so it's an incidence of around 25 to 30%. So this proportion of patients is already benefiting from the application of precision medicine.
Okay. What would you say are the main challenges in the implementation of precision medicine in AML in clinical practice? There's what happens in research, but in clinical practice specifically, what are the issues?
Well, one major issue is especially, of course, for countries that are less well-resourced, are the costs. I mean, all these new agents are very expensive. And not all, health systems can afford offering, these new drugs to their patients. That's certainly one big challenge if you think, globally. A second challenge is certainly molecular diagnostics. You need to have these data available within a short time window at the time of diagnosis. So, for example, if we talk about the application of the FLT3 inhibitors. So we need the result usually within 48 to 72 hours, and that's a challenge in routine clinical practice, and that is not available to all hospitals in all countries. So I think these are two main challenges I see, and of course. The development of new precision medicines is also a challenge. To conduct registration trials is becoming more and more difficult because we are talking about small molecular subsets of disease, and to conduct randomized trials in small molecular subsets is a big challenge because you need a large number of patients, and not a single study group can conduct these trials anymore. But we need international collaboration to be able to conduct these clinical trials.
And the last question, would you be able to tell us briefly about how precision medicine and ELN recommendations in treatment of AML go together? How is that represented in the ELN recommendations?
Well, I mean, that was one main reason why we updated now the ELN recommendations. The last update was in 2017, and as I mentioned, since 2017, 9 new drugs have been approved, and we have seen an enormous development in the understanding of the molecular pathogenesis of the disease, with all the new sequencing technologies, and that of course impacted both also the classification of the disease, but also the clinical management, and therefore we needed to update the ELN recommendation, and the ELN recommendation basically now reflect all these advances that we have seen in the development of the disease.
Well, thank you very much, Hartmut. I think that was really great information, and I'm sure our listeners will appreciate.
My pleasure. Thank you.